I'm Paula Nutting, your musculoskeletal specialist. When you have clients and patients that come to see you with aggressive chronic shoulder pathologies, we've got a number of issues that can come from. It can come from repetitive tendinopathies, it can come from bursitis, it can come from tears and strains. We can look at adhesive capsulitis. There's a whole plethora of issues that we have with the shoulder. What we can normally do in the clinic is look at active and passive range of movement. So when I'm doing active range, I'm getting my patient to come up through shoulder range, up and down, look at her external rotation and internal rotation, and abduction and adduction. And we listen for what they're feeling. So remember, we've got the scapulohumeral rhythm issue where they get caught from about here up through, so that about 60-degree arc where they really catch and feel uncomfortable. That can give us an indication that our glenohumeral joint is sitting a little bit more restrictive. We can get information where the bursa is inflamed and there's compression pain in there, or just in passive range movement. So passively when they're lying down on the table, I might actually feel that when I'm palpating, I can feel the head of the humerus sitting slightly forward, which means there's less space at the anterior portion of the GH joint. We do a bunch of maneuvers that will include myofascial release techniques, some glides, some mobilization techniques. But what can we give them for home care that will really make a difference? So you've got a couple of different apparatus that you can use. You can use these tubings, you can use TheraBands, but whatever you use, you've just got to make sure it's got a nice stable base and that it hasn't worn and tethered, because if you've got something that's been in the garage for 4 years, it's losing its capacity for strength and tears, then we don't want that, because we're putting quite a deal of force at the proximal head of the humerus, and we don't want to have something that smacks you in the head. So Lulu's going to take this and she's going to put it underneath the foot on the same side that we're having questionable shoulder range. She's then going to take it up and over her shoulder, but it's going to sit at the humerus, not on the shoulder joint. So we're down, we've got the humerus here, we're down about 4 to 5 centimeters, and then she's going to elevate this arm and we're going to keep it up here so she's got a nice firm base. Yep. This hand's going to come down and she's gently pulling down with this hand. That's it. So you should feel that distraction.
Yeah.
So coming down and then relaxing. You can actually encourage by drawing through your latissimus dorsi, so she's activating some of those deeper back muscles, part of the functional back line.
There we go.
Yep. And we're going to be doing this distraction and relaxation for a good minute. So it's just down and then up. And as that weight comes up, she's going to allow her shoulder, allow the humerus to rest up and then come down again and elevate up. So you'll always show this in the clinic first to really make sure that they've got a good handle on what they're doing. That wrist looks a little bit awkward, so I'm going to get
I have
her...
very lax wrists.
That's it. So you should be able to feel that dropping down.
Yeah.
So this could address issues with shoulder pathologies, many shoulder pathologies. If you have got an unstable or hypermobile person, this would be contraindicated. We wouldn't do this one. We need to give it strength, support, taping, and strength and exercise work. And you'll see that in some of the other videos on rotator cuff strength that I've got in the website. How's it feeling?
Very good.
Yeah.
I can feel it working for sure.
Great. I'm Paula Nutting, your musculoskeletal specialist.